presenting a case, so successful percutaneous closure under image guidance of a delayed pseudoaneurysm presenting as a massive pericardial effusion done by my guide, Dr. Prasad Shah. It was a 55 years old female, hypertensive and hypothyroid. She had undergone angioplasty to LAD in 2018 with a 3 by 38 stent. This time she presented with the history of exertional dyspnea and chest pain since 1 month. Echo showed a LV of 35% and ECG showed QS and V1 to V3. The angiography done showed LAD had 100% occlusion at the stent inlet. To ascertain the viability, a PET scan was done which showed a viable LAD territory. So angioplasty was performed to the LAD from the ostium using a 3 by 48 everolimus eluting stent from the ostium, and the previous stent was covered in its entirety. 1 week post discharge, when the patient was seen, she was asymptomatic, but 10 days after the angioplasty, she had sudden onset of chest pain which was followed by breathlessness. ECG revealed no fresh changes. Cardiac enzymes were normal and echo done showed a pericardial effusion 5 mm anteriorly and 10 mm posteriorly with no evidence of tamponade, not tappable. She was managed conservatively then, but a repeat echo after a week showed effusion which has progressed to 15 mm anteriorly and 25 to 30 mm posteriorly with a possibility of LV rupture and no tamponade. To confirm this, we did a transesophageal echo which also showed a dropout in the apex, so it was not confirmatory. So a cardiac MRI was planned which was suggestive of a sealed LV rupture along the anterior apical segment. But even that was not very, they were not very sure of it. So we planned for a LV angio which showed no LV rupture. However, a CAG which was followed, it showed an aneurysm at the proximal segment of the LAD stent. So this is the angio shoots which showed a LAD occlusion at the inlet, and this was the stent which was placed, and post angioplasty showed a good result. So after this angioplasty, she had the 10 days after this angioplasty, she had all these events. So these are the echo images which shows massive effusion with the clot in the mainly in the posterior wall. Over here we can make out there is a dropout at the apex which is suggestive of a rupture. Even the TE showed a similar finding, for which the cardiac MRI was done, and it was suggestive of a sealed LV rupture. So we did a LV angio. Here I want to point out the stent over here in the LAD and the pericardial margin over here. So there was a massive effusion, but there was no LV rupture. So the angiography which followed showed a aneurysm at the proximal site of the LAD stent, which was not free flowing. So it was followed by a OCT to make sure it was an aneurysm or a pseudoaneurysm. So this is the OCT run which shows a pseudoaneurysm in the proximal part of the stent. The length was around 6 mm. The aneurysm length, pseudoaneurysm length was around 6 mm, and there was also a red thrombus in the proximal LAD, where the LCX and the left main were healthy. So the length of the pseudoaneurysm was 6 mm and the vessel diameter was found to be 3.3 mm. So we decided to deploy a 2.8 by 19 mm covered stent. It was delivered with the help of a 6F guidezilla to prevent trauma. Since the ostium of the LAD was free of pseudoaneurysm, care was taken not to cover the care was taken to cover the aneurysm in the LED and make sure the LCX ostium and the LED ostium are not covered. It was deployed at 20 ATM. Here we can see the the stent is being delivered with the guidezilla, and immediately post the deployment, the pseudoaneurysm has been covered. Post deployment, the OCT run showed a eclipse sign, which was suggestive of a good stent deployment. It also showed that the thrombus had shifted from the proximal LED into the distal left main and the L6 ostium. Here we can see the pullback over here. There are blood artifacts, and over here we can see the eclipse sign. So the angiography also confirmed the shift of the thrombus into the LCX and the distal left main. So it was decided to cover the ostium of the LED with the stent, which went from the left main to the proximal LED. The LCX was wired, and the LMC2 LED was stented with the 3.5 by 15 deglutiting stent at 18 ATMs, followed by dilatation of the proximal LED using the same balloon. What was done in the distal left main with the 5 by 8 balloon dilatation catheter, the L6 wire was removed and recrossed in the L6, and the struts were separated using a 2 and 2.5 NC balloon. Kissing dilatation was performed using 4 by 12 and 2.5 balloon dilatation catheters. So after these post dilatation, the OCT run again was taken, which showed mal-opposed stent in the distal left main, the length being 3 to 4 mm. So it was decided to re-perform the pot in the distal LMCA. Over here, inadvertently the L6 wire came out, but still we went ahead and re-performed with the pot in the distal LMCA with 5 by 10 mm balloon. So post expansion, a slow flow was noted in the LCX. So the LCX was rewired and stent strut was enlarged with the 2.5 balloon, and final kissing dilatation was performed with 2.5 and 5 mm balloons. So this is the pre and post images, the 3D reconstruction, the pseudoaneurysm which is noted over here in the LED. After post graft master, that has disappeared. So the final result and the take home message is the rupture of the LV or rupture of coronary artery should be looked for in presence of pericardial effusion immediately post PCI, and we have to use all modalities of imaging to confirm the diagnosis, which may be missed on non-invasive modalities. And the intracoronary imaging helped us in confirming the diagnosis, planning the intervention and optimization of the procedure. Thank you.